Hello everyone. I'm Dr. Zubair Ashraf and today we will be discussing about management of pneumonia. In an earlier video, we discussed what are the clinical presentation, clinical symptoms and signs related to pneumonia and how pneumonia is diagnosed. And today, in continuation of that lecture, we will discuss how we manage a patient of pneumonia. So to summarize, the diagnosis of pneumonia is based on symptoms and signs of an acute lower respiratory tract infection, new radiographic shadowing for which there is no other explanation, and at least one systemic feature out of sweating, fevers, myalgia, and there is no other explanation for the illness. So when there is a combination of these findings, then we diagnose a patient with pneumonia. The next step, once the diagnosis is suspected, is to assess severity of pneumonia because that is needed to decide about the place of treatment. One of the scoring system which is used to assess the severity of pneumonia is CURB-65 score. It consists of five variables: C for confusion, U for urea, respiratory rate, blood pressure, and then the age. So if the patient is confused, patient is drowsy, or their mental test score is 8 or less, then 1 point is awarded. If urea is more than 7 millimoles per liter or more than 20 milligram per deciliter, then again 1 point is given. And respiratory rate more than 30, blood pressure systolic less than 90, and diastolic less than 60. These are again assessed, and 1 point each for respiratory rate and blood pressure is given. And if the age of the patient is more than 65 years, again, that is also 1 point. So on the basis of these, the patient can be divided into, they will fall into one of these three groups. If patient is scoring 0 or 1, then they can be treated as an outpatient or home treatment can be given. If the score is 2, then they need some sort of supervised treatment that can be given in the hospital or that can be given at home as well. But if they are scoring 3 or more, then they will need to be admitted. Especially if they are scoring 4 or 5, they need to be admitted in an ICU. So CURB-65 score helps us in assessing the severity of pneumonia, and it also predicts the need for hospitalization. It also is helpful in determining the mortality risk. More the score, the higher the mortality. As you can see from this table, if the score is 0, the mortality risk is 0.6. But if the score increases to 4 or 5, the mortality risk is 27.8, which means almost around one third of the patient with these scores will die while they are in the hospital. So that is classified as severe pneumonia, and patient will need to be admitted in the intensive care unit. Going back to the clinical scenario, which we discussed in our first video, the 60-year-old male presented in medical emergency with complaints of productive cough, high-grade fever, and chest pain for 5 days. He is a known diabetic taking insulin. So diabetes is a risk factor for pneumonia. And on examination, he had respiratory rate of 32 per minute, heart rate of 110 per minute, blood pressure of 85/60, and coarse crackles in right lower chest. He is alert and oriented. Oxygen saturation 89% on air. Hemoglobin, white blood cell is 24,000, suggesting an infection. Urea is 10 millimoles per liter. So what is the CURB-65 score in this patient? So let's calculate the score. C for confusion. So there is no confusion. He is alert and oriented. U for urea. Urea is 10, which is more than 7. So 1 score for urea. Respiratory rate in this patient is 32. Again, 1 point for respiratory rate, and blood pressure is also low with systolic blood pressure of 85, which is less than 90. Again, 1 point for this as well. And age is less than 65, so no point for that. So patient is scoring 3. So that means the patient needs to be admitted. So what would be the place of treatment in this case? So usually 3 or more patient needs to be admitted, 4 or 5 need to go to the ICU, but this is not very hard and fast rule. We have to consider other comorbidities or other medical issues which the patient may be having. So patient is falling in the third group with score of 3. Patient will need to be admitted. Coming to the management, once the patient is admitted in the hospital, how will you manage? There are some general things like if the patient is needing oxygen, if saturation is less than 94%, oxygen should be attached, and ABGs should be done in these patients to get to know the type of the respiratory failure, whether it is type 1 or type 2 respiratory failure, and oxygen should be given accordingly. If it is type 1, the saturation should be maintained above 94%. Fluid balance, if the patient is dehydrated, we'll need IV fluid or oral fluid depending upon the severity. If the patient is overloaded, they may need diuretics. Analgesia, patient will have fever, so should be given paracetamol or other antipyretic or an analgesic if they have chest pain as well. It is common for the pneumonia patient to have chest pain. Paracetamol is usually helpful in relieving fever and pain as well. Nutrition, if patient is able to take orally, then oral nutrition. Otherwise, other form of nutrition like the nasogastric tube can be used. As these patients are mostly immobile, then or they have less mobility, DVT prophylaxis should be given. That can be given in the form of heparin. Physiotherapy, once the patient start to recover, physiotherapy can be involved depending upon the mobility and functional baseline status of the patient. Now, coming to the most important part of the management of pneumonia, antibiotic selection. Again, CURB-65 score helps us in determining the antibiotics for these patients. So, in this case, if the patient is being treated as an outpatient, if the patient's score was 0 or 1 and they do not have any comorbidities, we have three choices. One of them is amoxicillin 1 gram 3 times a day, or a macrolide like azithromycin or clarithromycin can be used. And the third option is doxycycline 100 milligram twice daily. For second group of patients, which do not have high score on CURB-65 criteria, they are scoring 0 or 1, but they have comorbidities. The antibiotic choice would be different. They should be given beta-lactam like amoxicillin clavulanate, cefpodoxime or cefuroxime, and a macrolide or doxycycline. So they will need double antibiotic cover. Or they can be given single antibiotic in the form of respiratory quinolones, which are moxifloxacin and levofloxacin. One of them can be used. Once the decision has been made to hospitalize the patient, then there are different antibiotic choices. One option is to give beta-lactam like ampicillin, sulbactam, or ceftriaxone, or cefotaxime, or ceftaroline. These antibiotics should be combined with a macrolide like azithromycin or clarithromycin. Or you can give a single antibiotic in the form of respiratory quinolone. Or another option is if the patient is sensitive or to any antibiotic or these are contraindicated, then beta-lactam, which I mentioned earlier, they should be combined with doxycycline. Patient's temperature, respiratory rate, vitals, oxygen saturation, mental status, these should be monitored closely, especially if the patient is having severe pneumonia and they are in the ICU. They have high chances of complication and mortality. And CRP and repeated chest X-ray in only those patients who are not improving on the third day of treatment. Usually we give 48 to 72 hours of time for the patient to start improving. Some patients can improve early, some patient may be delayed, but you should look for complications if they are not responding in 2 to 3 days after starting of antibiotics. In ICU, there will be combination of beta-lactam like ceftriaxone, cefotaxime, or ampicillin sulbactam along with the macrolide or respiratory quinolone. And if they have allergy, they should be given quinolone along with effusion. The duration of antibiotic therapy depends upon the severity of illness. If it is low severity, low CURB score, then usually 5 days are enough. If moderate to high severity, then 7 to 10 days. In some cases, extended treatment up to 14 to 21 days may be required depending upon clinical judgment, especially if the patient has pneumonia due to staphylococcal disease or gram-negative enteric bacteria. So usually clinical symptoms, especially fever, And then markers of infection like CRP, white blood cell count, procalcitonin, they can help us in deciding the duration of treatment. Going back to our clinical scenario. So patient was started on antibiotics. After some initial improvement, he again started having high-grade fever on fourth day of admission and was tachypneic and tachycardic. Examination of chest showed reduced chest movement on right side along with dull percussion note and reduced breath sound as well. If you remember, previously he was only having crafts. Now there is change in this examination finding, which is very important to examine these patients because this represent a an important complication. So white blood cell and CRP was still raised. A repeat chest X-ray was done. If you remember, this X-ray is different from the initial X-ray. Initially, there was this non-homogeneous opacification, which has turned into a homogeneous opacification, dense opacification with concave upper margin. And you cannot see the diaphragm, the right heart border, and the costo and cardiophrenic angle. So what do you think has occurred in this patient? Patient has developed pleural effusion, and it is possible that the patient has developed empyema. So what happens in pleural effusion? There is collection of fluid between the two pleural surfaces, the visceral pleura here around the lung and the parietal pleura. And when this fluid is pus or it has bacteria inside, then this is called as empyema and that will need drainage. So pleural effusion and empyema are two of the complications which can occur after pneumonia. Other complications are lung abscess, especially in anaerobes, sepsis when there is disseminated infection and dysregulated host response. Respiratory failure, severe pneumonia can cause respiratory failure, usually type 1, but can cause type 2 respiratory failure, especially in patients having COPD, in patients who are obese, in patients who have got OSA or OHS. So ABGs are needed in these patients to differentiate between type 1 and type 2 respiratory failure. Brain abscess, the organism and the infected material from the lung can go to other organs of the body and cause disseminated septic embolization, for example, in brain. And it can also cause pericarditis, myocarditis, and hepatitis as well. Discharge is done once the patient does not have any of the following. Temperature has settled, heart rate is normal below 100, respiratory rate goes less than 24, blood pressure has settled and is more than 90, so the systolic blood pressure, and patient is maintaining oxygen saturation more than 90% without the need of supplemental oxygen. Patient is able to maintain oral intake and patient's mental status is back to normal or whatever the baseline was. When all of these points are met, then the patient can be discharged. Follow-up X-ray usually after 6 weeks is done only in patients if they have got persistent symptoms. If the symptoms have not completely resolved, then the X-ray should be repeated after 6 weeks, especially in patients who have got risk factors for malignancy, because sometimes a pneumonia can be presenting feature of an underlying malignancy. To prevent pneumonias in the future, patients should be vaccinated. They can be vaccinated at the time of discharge or when they come for follow-up. Pneumococcal vaccination is important. Similarly, yearly influenza vaccination and COVID vaccination should also be given to these patients. So this was all about pneumonia, how to manage, how to categorize the severity according to CURB-65 score, and how to decide about the place of treatment, what are the various antibiotics treatment options which should be given, and how to look for complications of pneumonia in these patients. If you have any feedback, any question, or any topic, any other topic which you want me to discuss, then please leave your message in the comments. Thank you.